Welcome to the Putcast podcast by Pharmacists United for Truth and Transparency. Pharmacists United for Truth and Transparency is the only registered 501c3 nonprofit wholly dedicated to exposing the hard truths about pharmacy benefit managers and how their greed-centered, profit-at-any-cost business practices are driving up drug prices and healthcare premiums while reducing consumer choice and endangering patient access. To learn more, visit our website at truthrx.org.
Hi, and welcome to this episode of the Putcast, brought to you by Pharmacists United for Truth and Transparency. I'm Lauren Young, and I'm very proud to bring you Mark Boesen of Boesen Snow Law firm. Welcome to the Putcast, Mark.
It's my pleasure to be here.
I'm glad you could be here. It has been a whirlwind of activity on PBM reform and executive orders and all of that over the last few days. So we're very glad to have your expertise in just guidance and information on this. Usually when health professionals over the last couple of years have heard executive order, it has to do with a global pandemic. And so whenever we saw this executive order, we heard there was PBMs and drug pricing reform, we thought, finally, we're getting rid of the parasites that have plagued us for the better part of 2 decades. But there's a lot to unpack in this. There's 11 different sections that were broken down in the PDF that you were so gracious enough to put together for PUT and describe this. We sent this out in an email blast. It's also posted on our website and other sites so people can reference that as well. But I know one of the biggest pieces that we've heard about so much has been the drug price negotiations around the IRA.
I appreciate the opportunity, and this executive order, to your point, is different than the executive orders we saw during the COVID period of time, particularly because these don't have the immediacy of those COVID executive orders, and they don't have the bipartisan support to just allow them to just happen. So executive orders that happened during the pandemic, whether they were issued by a governor or the White House during that time, there was broad bipartisan support for most of them to just let them happen. All of those things seemed like a necessary thing. And when you have bipartisan support and the president has things that need immediate implementation, you tend to have them. In this case, this executive order is more platitude. It is more of a blueprint for what the president wants to see happen. Some of the things can happen right away because they're within the authority that's granted to the administration by Congress. The Inflation Reduction Act is one of those. One of the things that is very concerning, particularly to our long-term care brethren out there who operate pharmacies, the first 10 drugs that the IRA, the Inflation Reduction Act, decided needed to be negotiated represent in many cases up to 80% of the medications that are used in nursing homes. And for pharmacies that are supplying medications to people who are in skilled nursing facilities or assisted living facilities, the cost controls, the prices that the White House under the Biden administration negotiated weren't clear about who was going to bear those costs. There's no requirement in the Biden administration's cost negotiations that the manufacturer actually lower the price to the pharmacy. Manufacturer has to lower the price, the maximum fair price that's being allowed to charge to Medicare. But the big issue is, but manufacturers don't sell drugs to Medicare. Pharmacies sell drugs to people, and we bill Medicare. And so I don't really care what the maximum fair price is that the manufacturer agreed to. They're not the ones selling the product. And so one of the things we brought, we as a community, not just PUT, not just state and national pharmacy associations, but our law firm said, this is going to devastate pharmacies because it's not clear who's going to bear the discount. And for the history of time, since there were third-party payers, the discount is usually borne at the pharmacy counter. I've argued that we're the biggest charity in the world. And we just we run a business where we hope to make more money than we lose on the products we sell on a weekly basis. And that's insane to me that they ask our profession to do that, but that's where we are. During the transition period between the time Trump was elected and took office, we spent a considerable amount of time with the transition team, and particularly with Dr. Oz, talking about this problem. If you want to negotiate prices, we're going to be agnostic on that. Get the best price you can. As a taxpayer, that's a good idea, but not on the backs of pharmacies. So that's one of the things we need to be careful with. There are two provisions in the executive order. One talks about lowering prices more aggressively. And what do I mean by that? Adding more drugs to the price negotiation list faster than the Inflation Reduction Act requires, and leveling the playing field between when price negotiations can happen on new drugs. So right now for biologics and specialty drugs, 13 years after their introduction, you can start negotiating prices. Interesting to me that they picked the number 13. For what they call small molecule drugs, and I don't like the word small molecule because that means something to us as a profession, but what they mean are non-specialty drugs. And those are your routine, could be generic medications, or it could be a new cholesterol lowering medication. Anything that's really non-specialty, if you really want to break it down. And those could be negotiated 9 years after introduction. And so one of the things the president did was, well, wait a minute, why would anybody ever bring a new novel medication to market if on one hand, a non-specialty drug gets hit with price negotiations 9 years after invention, while a specialty drug gets hit 13 years after invention? We're gonna make sure those numbers are the same, so there's no perverse disincentive for people to bring new, novel, less expensive, non-specialty therapies to the market. And so that's something the Inflation Reduction Act doesn't call for and would require congressional action to implement. So that's not going to happen overnight. But one of the things they talked about, though, is the price disparity between classes of trade. It's not very well culled out. And if you look at Health Affairs and you look at some of the more sophisticated or well-known mainstream media analysts, they didn't cull this out, but we did, which is the concern the White House has over class of trade issues. We've had this problem in the United States since the 1970s, where hospitals can acquire drugs less expensively than retail pharmacies do. Retail pharmacists, as we know, particularly independent pharmacists, pay more in acquisition costs than any other class of trade. And we're at a competitive disadvantage then to almost every other system, the larger chains, outpatient hospital pharmacies, federally qualified health centers who can get things at 340B. And what the president has said is, look, let's do a couple things with classes of trade. Not proposing getting rid of 340B, but making reimbursement for 340B medications more closely resemble their acquisition costs. The windfall profit that 340Bs can earn, particularly for disproportionate share hospitals and children's hospitals, where you've got those employers that are making their employees get their medications at the outpatient pharmacy so they can get these windfall profits on routine and specialty drugs. That's going to go, he wants that to go away. That's just gaming the system and doesn't achieve its purpose. It's what's encouraging by the language in the EO is we got to pay for the drugs at the acquisition cost that is incurred by the facility we're paying. So if the facility is paying less for drugs, we're going to pay less for drugs. Conversely, that by that logic, if a pharmacy is paying more for drugs, we've got to pay more for drugs. We've got to do one of two things. We've either got to lower the acquisition cost to those people like independent pharmacies that are paying the most, or we've got to increase their reimbursement. One of those two things has to happen.
And we'd be in favor of both of those. That's fine.
We would be in favor of both of those. I often lament that one of the best contracts we can negotiate is at least pay us the cost of the medication plus something else as a dispensing fee. And that would be a good contract. If we got acquisition cost plus $1 dispensing fee, that would improve our lives tremendously. It's not enough. Mm-hmm. We need the cost of the drugs probably, but but another $25, $30 for our services. We'd like to see a world where that happens. And the easiest place to get that is by lowering the acquisition cost and then paying us the fair market value for the services that are done. And the president also sort of forecasts that too, which is and that's the piece about the PBM reform he talks about, which is reducing the incentives that the PBMs have to engage in price spread. And he didn't go so far as to renew Trump drug pricing 1.0, which was his first administration, where he was going to remove rebates, making them kickbacks again. I often want a hat that says, let's make drug rebates, kickbacks again, because then they'd be illegal. He didn't call for their complete elimination, but what he did say is that there needs to be transparency. He's going after pricing spread. And he's also forecasting that he wants formulary decisions to be removed from the PBM altogether. And so there is no one that can pay for play, meaning I want to be on your formulary. Tell me what rebate you need to make me preferred, even if it's a brand name drug with a generic available. What do you need to make me preferred? Because all of that money is kept by the PBM. The White House does know, and DOGE is looking at this, I know this, that even though Medicare requires all of the rebates that are provided for Part D benefit be returned to CMS, they're not. We all know that. And so they're looking for evidence of that. And we're starting to see that. In some of the Medicaid reports, some of the states are doing a nice job with their Medicaid reports and exposing the spread, exposing the lost revenue that they should have earned through rebates and other things. And so the president is attacking rebates. He's trying to get PBMs. One of the things that's encouraging, and I hear this from the Office of Management and Budget, and I like it. There was allegedly a quote, it might be an urban legend, but I'm going to go with it and call it fact. There was someone at the OMB who said there's nothing special about specialty medications. They're just really expensive. Mm-hmm. And because all the lip service that the PBMs play of, we've got to keep these in-house because we're white glove. I'm like, I don't know what white glove service these specialty pharmacies are providing that are owned by the PBMs.
Absolutely. And that's what Arkansas really was showing this week in their monumental win of having to have PBMs choose between being a pharmacy or a PBM and be licensed in the state of Arkansas. They had over 600 mail order pharmacies registered in the state of Arkansas. And with this, I believe around 100 are now affiliated with a PBM, so they are out. That still leaves 500 mail order pharmacies that people can utilize in Arkansas if that's the method of delivery they want for their prescriptions. And so I think it's so interesting that there are pharmacies fighting to just have that level playing field. And that's exactly what we're wanting.
It is exactly what we're wanting. And I'm also encouraged. I love Arkansas. Arkansas has been a leader on a number of fronts with making sure that pharmacies are treated fairly. Arkansas 900, and then the Rutledge decisions in the Supreme Court comes out of Arkansas.
I agree. As long as you're wanting patient access, because that was really the goal. That was what Arkansas Pharmacists Association set out, was for having the accessibility for patients to have the choice and not have to go to a PBM-owned pharmacy where they were going to receive steering letters, where they were going to receive steering calls. I mean, there was so much that they had to work against. So this is just a monumental task to even take on. And the fact that they were able to complete that first hurdle of getting it through the chambers of the legislature and then signed by Governor Sanders is a great feat. And hopefully there are other states we know there are that are looking at doing something similar, because it seems as goes Arkansas, as goes the rest of the country in PBM reform, which is a great model to have. You kind of mentioned Trump PBM reform 1.0, is that we've heard, obviously at the end of last year, that yes, he was going to try to tackle the middlemen in drug pricing. And then there have been discussions of health insurer CEOs, kind of not in his ear, but maybe at the table. And so we just give us an idea of if the administration really does understand how bad PBMs are as actors in the healthcare space, because we have decades and millions of claims worth of data that we have given to every alphabet soup acronym agency that we can. And, owners are just waiting, but they kind of feel like Lucy and Charlie Brown with a football.
Yeah. And I have the same concern. I'm as tired as everyone else is. I've been a pharmacist for 30 years. This is not a new problem. This problem just seems to be getting worse and worse and worse. So let me talk a little bit politics here. I'm worried about his pharmacy agenda and his healthcare agenda. I'm worried it's not as sexy to him or as important to him. But even more important, I'm worried about the people that he has who are different this time. He has different secretaries. He has different deputies. He has different presidential appointees. And we've got to re-educate all those people all over again. And we have one of the most complicated business models that's ever been dreamed up. And to explain this from the beginning to someone who has not come from this industry is exhausting. I'll give you an example of a conversation I was having with one of the OMB people, and we were talking about PBMs, and he was very humble, and he said, look, I'm supposed to know what prescription benefit managers are, but I don't. Can we just have a conversation? I said, yes. And so I'm walking him through it, and we've got the whiteboard, and he's just like, wow. And he's like, all right, I have a second question. I think I got it. And he's like, what's a PSAO? And I'm like, I don't think you're ready for that. Your head will explode. And he's like, tell me they're not middlemen to middlemen. I'm like, oh, you do know. Yeah, that's what they are. And he's like, let me get this straight. You people, and meaning the world of paying for pharmacy, decided that PBMs were a good idea. And they were at the beginning, which is you're just going to process the claim to get the money faster in a world that had no internet and no personal computers, and the pharmacies are going to get their money faster. And you're going to pay a small portion of what you receive for that service. Everybody was happy. And they're also going to help you order drugs from the manufacturers, because we had to order them, manufacturer at a time instead of, just one big McKesson order at the end of the day. And then that devolved into evil incarnate, which is, we can do all these other things, which is actually own your competitor, actually decide what you're going to get paid, actually drive the formulary. And it was all this pay for play. And they devolved from something that was actually envisioned by a pharmacist and invented by a pharmacist into something that poor Charlie Polito is probably regretting. And he says, okay, so to overcome that problem, you guys created PSAOs. Yep. And then that got away from you. Yes, it did. Yes, it did. That was originally a really good idea, that the PBMs weren't on our side anymore. So we needed a middleman to the middleman that was on our side. And then that got away from us too. And he's like, you guys got to have shorter leashes. I'm like, oh, no doubt. Yeah. The next one, he's like, tell me you're not going to create a middleman for the middleman for the middleman. I'm like, no, I think we just got to get rid of it all. That's the answer, right? Let's just erase this whole thing and just say, drug costs X. I got a very expensive pharmacist here who's necessary to make sure that people are getting the right drug at the right time and aren't getting hurt and are actually maximizing therapy. I also talked about, the patients who are on 30 medications who probably could get away with 5, and only the pharmacist figures that out. And you got to pay us for that. Right now, your biggest problem is if I take the 30 medications down to 5, I've got a perverse disincentive to make sure those 5 are the profitable ones. You got to take that out of my hands. Mm-hmm. Stop paying me for the commodity. Make my fee separate 100% of the time. And then you pay for the cost of the drug plus a fair market value for the wholesaler or whoever sold it to me. Fine. And so one of the things that's in the executive order is more creative pricing proposals. And they don't like the IRA. That's just a straight negotiating price, and it seems like price controls, and that's not American, and that doesn't drive innovation. One of the things we're trying to do is if you can make the acquisition cost to the pharmacy, not the price to the payer, because when we talk about price to the payer, the pharmacy always loses. Acquisition cost to the pharmacy, if you can make the acquisition cost to the pharmacy for your new drug $100 a month per patient or less, we'll reset your patent. So right now, drug manufacturers chew up most of their 20-year patent in research and development. On your PDUFA date, if your acquisition cost per patient per month is $100 or less to the pharmacy, and we can negotiate the health plan, pay us more for that, we'll reset your patent for another 20 years. Because what's the big argument? I got to recover my research and development costs. Well, let's just reset your patent then, give you more time to recover those and give you some market exclusivity. And then let's go crazy. If you can make your per member per month price acquisition cost $50 or less, double your patent, give you 40 years exclusivity. Those are some creative proposals that do two things. One is they don't stifle innovation. They make America still the leader in technology and innovation for drug development, and we always need to be. It also takes care of Americans. We won't end up with Zepbound that costs us $400 a vial, but in India it costs $40 a vial. That's another thing that this executive order goes after, is the ripping off of America. And then also, it doesn't create this chasm between professional pharmacy and pharmaceutical manufacturers. Our profession doesn't exist without the manufacturers. Their profession doesn't exist without us. And so how do we work together on this one? And so that's something else this executive order does, is it charges the agencies to come to him with just more creative thinking. Let's just tear up the rules and start all over again. What's the ideal system look like? I'm encouraged that there's a lot of platitudes here, but to your question, is it going to work this time? I'm worried that it's not a high enough priority. I'm worried that it's too complicated to solve. I'm worried there are easier things to solve, and those are going to take the front of the line. We've got to make sure that these lawmakers and these people understand that we're concerned, and we're going to make an investment in them so that they can make an investment in us. And I want to say it's not how you do it, but that's how you do it.
Yeah, absolutely. Well, you kind of mentioned also that it's so hard to unravel, hard to understand. You know, you've talked to people, you've tried to educate them on every piece of the puzzle, but there's so many layers to the onion that is PBM and drug pricing reform that, you know, a lot of people have said, why don't we just repeal safe harbor laws? And that will kind of goes to your kickback comment earlier. So is there a way that you think that could be introduced? Something along those lines could be introduced, because PBMs wouldn't be able to get all of the money and rebates and things like that they're able to get. And if you take away their funding source, or a majority of their funding source, then that should help calm that beast.
I think you're absolutely right. I think that's one of the easiest things to do, because it's not complicated. It's one thing. To your point, we do one thing at a time, and that would be a big thing. The criticism of that idea that I hear over and over again is that doesn't solve the problem right now, because if the drug costs $1,600 and $800 of that is a rebate, we just see that pharmaceutical manufacturer just deciding, great, now we have $800 more to work with. That is probably true. Is the price going to come down $800 because they're not paying the $800 in rebates? Probably not. But every drug after that won't be overly inflated because they had to bake in a rebate. Mm-hmm. And so at least we stop the bleeding.
That's, I mean, the counterpoint to that is, well, the system is well past broken. So unless we just go to that giant whiteboard and just erase everything and say, great news, we're going to start over. This experiment with PBMs in the middle, did not work. Patients are being impacted severely. Pharmacies are closing daily. There is no help on the horizon. There was just 39 attorneys general who sent out a letter saying, we're doing our part on the state level. We would really like it if Congress was able to help out and tackle some of those plans that we know that Congress can make some impact in. And so that's really what we are hoping we can get moving.
Well, and I like this idea of getting rid of the kickback safe harbor, because when we talk about what can Congress do, we always talk about they can only affect Medicare and Medicaid, which on one hand is true, except for if they get rid of the kickback safe harbor, then that helps the entire system. That's something Congress can do that affects every single person buying medications and selling medications.
We kind of talked a little bit about mixed messaging. I know that over the last couple of months, there's been some discussion about the FTC. On the pharmacy side, we've been talking about the FTC reports and trying to make sure that all of our legislators know what was in them, what some of the findings of those interim reports are, so they can understand that the evidence that thousands of pharmacies put forward was all compiled, was all looked at by the government. With the firing or attempted firing of the two Democratic FTC commissioners, with former Chair Khan stepping down, what do you see happening in some of the other agencies, whether that's VA, HHS, with DOJ? What are some of those directives that they're going to be able to take?
Well, I worry, to your point, one of the things I worried about is that this drug pricing EO has too many points in it. They're trying to do too much. And the congressional bills that have been drafted and are not moving or have just expired because of the congressional changes in terms, in many ways, I think there's too much. And what I would encourage us to do as a profession is not want the perfect bill. It'd be okay to ask for one thing at a time. I think it would be very, very difficult for Congress to say rebates are a good idea. No one thinks rebates are a good idea except for the PBMs that are keeping them. And so if it was just rebates, one of the things that I worry about, because I've been doing political advocacy for so long, is I think sometimes our national associations, the NCPAs of the world, the APHAs of the world, are like, if we don't try to satisfy 80% of our members, we're gonna lose our membership. And these people want it all fixed right now. And so I'm often lament like, oh, that's great. You launched a very, very pretty bill. It is dead on arrival. It is too expensive. It is too complicated. And you have as a co-sponsor a freshman minority member of Congress. That's going to impress the amateur that you're trying. And every year you could say, we tried and it didn't work this year. No, you didn't really try. You didn't take the hard position and say, you know what, we're going to do one thing this year. And we're going to focus 100% of our money and effort on that, which is the safe harbor piece. I like that as a starting point. And no, it's not perfect. And no, it's not everything you want. But we never get everything we want. Comprehensive PBM reform is a pipe dream. We'll get it eventually, but we got to start one at a time. And I like that plan. I think the president's agenda is too aggressive. It's 11 things. Do less.
It's throwing your entire pot of spaghetti against the wall and just seeing if there's enough for dinner that sticks.
It really is. It's got everything in there, from the Inflation Reduction Act, which was complicated in and of itself, to 340B, which is complicated in and of itself. There are health lawyers who don't know 340B, and everything in between. And people there was too much. And I was actually surprised that this president tried to put so much into this, and it scares me. It's like, well, I tried. You guys saw my executive order. Congress didn't act on any of it because,
I think that other leaders, though, if they weren't part of the first Trump administration, because we kind of talked about that as well, that there's a whole new face of directors and agency heads, going on in this administration, do you have faith that they will be able to catch up quickly or understand a lot of those different moving parts that's going on with PBM reform? Because a lot of the time, that there is thousands of other issues that they also have on their plates. As you mentioned, in healthcare, there's 340B, there's rebates, there's spread pricing, there's all kinds of things. And so we want them to obviously be very well informed. But is there anything that you can, whether it's suggest or just give faith that hopefully they've been able to do some kind of homework? They can at least spell PBM?
I think the strategy to go forward and let's work together on this is one of the things that frightened me about Dr. Oz's first meeting with the CMS staff. And the CMS staff were pretty public about how underwhelmed they were with their new administrator when he talked a lot about health and nutrition and very similar things that is on RFK Jr.'s list of making America healthy again. I am 100% on board with making America healthy again. But the people at CMS take care of, they pay for healthcare. They don't influence healthcare other than payment methodologies. And most of the healthcare they pay for at CMS are for people at the end of the life. And it seems macabre to talk about, but they're like, we take care of people who are dying. And we don't get the opportunity to influence payment decisions when people are younger. That's not the constituency we take care of. And so even Dr. Oz is coming in with we got to make America healthy again. And CMS is saying, but we're taking care of people at the end of their lifespan. We got to do more on the front end, and that's on the commercial side. Mm-hmm. We got to do more to make sure that our payment policies that come from the private sector before you become Medicare eligible are better than they are now. And right now, our payment policies are based upon which manufacturer can send me the most money, and it ought not work that way.
I absolutely agree. And I think it's so frustrating whenever we do talk about those pay-to-play formularies because legislators cannot understand. They get about 80% there. They can understand that a drug maker, a manufacturer would want their drug they've spent billions of dollars to get on a formulary and be placed as a preferred item on that formulary. They even understand that the individual or the company that's in charge of that formulary wants to have some kind of incentive to choose that drug on the formulary. But they haven't quite been able to marry the fact that the plan sponsor, the PBM, is the one that is holding the drug maker hostage in a sense of saying, great, you are able to have whatever drug you want on this formulary as long as you pay me the most money. Well, we're wrapping up here on our episode of the podcast. Is there any parting words of wisdom that you can leave our listeners with, especially in legislative advocacy season coming up, whether it is in DC or in your home state?
Yeah, I used to work on Capitol Hill a lifetime ago, and my boss, Senator McCain, always wanted to know what was going back home in plain English, in folksy terms, what was important. Bring your stories and what the plain English solution is. One of the most compelling pieces of policy that dealt with the EpiPen, and I don't know if everyone remembers when EpiPens went all of a sudden from things that were affordable to $600 for the 2-pack, and it was the Mylan version. And Congress was like, what happened? Well, what happened was we had a consolidation in the industry, and when you break down, NCPA did a really nice slide on it. When you break down that $600 cost, more than half of it went to rebates, because it was the last remaining sort of unit on the market, and it was held hostage. It was sort of this espionage. And so come with your screenshots that are redacted with PHI, obviously, of here's a medication that you're likely on. Here's how much I paid for it. Here's how much I got reimbursed. Here's how much of it you paid for, and how much I ended up with at the end of the day. If you're lucky, you've got some positive numbers, but even those positive numbers aren't And what I do is I always break down, it took 5 minutes for my technician who makes $25 an hour to type this. It took, the bottle, the cap, and the label cost me $2.35. And, and then I've got rent, and then I've got, you name it. And you lay those out in plain English terms, those will go a long way. And when someone says, hey, I got paid below cost, and for my entire dispensing fee, I got 25 cents, and that's somehow fair, let me tell you what this costs. And then have them picture a world, and this is my favorite thing, have them picture a world where there aren't any more pharmacies in their community, and they have to rely 100% on mail order. Can't be done with pharmacy. You've gone to the urgent care and you need the antibiotic and the pain medication right now. Picture a world where you got to wait until Monday for the one pharmacy that has a line out the door because it's the last one there. Mm-hmm. Picture those gone and what you have to do next, or how far you have to drive. And then we've got, and I also picture Cinderella's "You don't know what you got until it's gone" playing in the background. That's where we're headed, and it scares me to death. Not just as a pharmacist, as a second generation pharmacist, but I don't want to live in that world where I can't run out and get nebulizer tubing when we find out that we don't have any because it was gross and we can't use it again.
We are so grateful, Mark, for your guidance, your interpretation of the executive order. We really do value you as a resource for not only us at PUT, but also for pharmacists out there as well.
Absolutely. Appreciate your work too. PUT is an exceptional organization. Keep up the good fight. Do the things you're doing. We're not giving up.
That's right. I think the mantra this year is whatever it takes. I think that's really, whatever it takes to get the win, whatever it takes to keep the store open, whatever it takes to get the advocacy to the next level. That's really what we're going for. But Mark, thank you so much for your time. We greatly appreciate it. Thank you for joining us for this episode of the PUTcast. If you don't know us, we are from Pharmacists United for Truth and Transparency, or PUT, and you can join us at truthrx.org, and you can get a multitude of different resources. You can sign up for our newsletters. You can follow us on social media. You can really get a wealth of information from all of our outlets. You can also donate to our cause at truthrx.org/donate. We appreciate your time today, and hopefully you'll join us for the next episode of the podcast.
PBMs are robbing you day in and day out, making you work for below-cost reimbursements. Billion-dollar corporations hurting hard-working independent pharmacy owners as they line their pockets and put so many of you out of business. And now it's happening with so many pharmacy software vendors that have sold out to billion-dollar hedge funds. Are you truly happy with your pharmacy software vendor? Is support what it used to be, or you find yourself waiting on hold? Are your issues resolved in a timely fashion? When is the last time you took a look at the bill from your pharmacy software vendor? Perhaps it's time for a change. Visit our website at www.datascanpharmacy.com and give us a call at 1-877-222-7979.